Hey guys, welcome back to St3 Hacks, and today we're going to continue our Pete's theme and talk about Perthes disease. Sorry, I've been away abroad for a friend's wedding in India. I've come back and I hope to upload more episodes in the coming weeks in the lineup for your interviews. So, keeping up with the theme, we're going to talk about the pathoanatomy first. So, Perthes disease is an idiopathic avascular necrosis of the femoral head epiphysis in children. The underlying problem is interruption or temporary interruption of this blood supply to the capital femoral epiphysis, leading to ischemia, bone infarction, structural weakness, and then collapse under load. The disease progresses through predictable radiographic stages, which are described by Waldenstrom's classification. Stage 1 is initial, Stage 2 is fragmentation, Stage 3 is reossification, and Stage 4 is healed. The long-term outcome depends on how much the femoral head collapses and whether it remains contained within the acetabulum. The loss of the spherical shape predisposes to early degenerative osteoarthritis in adulthood. Prognosis is commonly assessed through using Herring's classification, which is the lateral pillar classification. It's based on the height of the lateral pillar during fragmentation. Group A is lateral pillar height is maintained. Group B is more than 50% of the height is maintained. And Group C is less than 50% of the height is maintained. This has good prognostic value and is commonly referenced in UK practice. And then there's the Catterall classification, which is based on the percentage of femoral head involvements in grades of 25%. Risk factors for Perthes disease. Firstly, boys are more commonly affected, 4 to 5 times more. Peak age is between 4 to 8 years, although it can occur up to 10 years. It's often unilateral and only bilateral in about 10% of cases. And there's no clear modifiable predisposing factors. Radiologically, early features of Perthes disease can be identified by the acronym MAB, M for medial joint space widening due to effusion, A for asymmetry and increased density, i.e. sclerosis of the femoral head, and B for blurring of the physeal plate. Early x-rays can be normal, and if clinical suspicion is high, MRI is the most sensitive investigation early on. The next stage is fragmentation stage, and the acronym here is FC, fragmentation of the femoral head, and then C for the crescent sign, which is basically subchondral lucency, indicating impending collapse. And late features, i.e. the healed stage, you can see things like femoral head flattening, also called coxa plana, or femoral neck deformity, plus or minus shortening, which is can be called coxa vara. And loss of the spherical nature, healing determines long-term function. The imaging that you normally require for this are an AP pelvis, a frog leg lateral, unless you're concerned about an unstable SCIFI, and further imaging, if required, you can get an MRI, which is useful in early diagnoses and assessing the extent. A bone scan is rarely used now, and an arthrogram occasionally used preoperatively to assess containment of the femoral head within the acetabulum, but again, very rare. Now, approaching this case should be in a triple assessment manner because you want to be systematic in your approach. In your history, you take a detailed Socrates pain history, pediatric history, talk about the limp, activity-related pain, duration, progression, night pain, systemic symptoms to rule out any infection or malignancy, past medical history, including previous admissions, developmental history, and always consider important differentials to rule out. So transient synovitis, septic arthritis, SCIFI, malignancy. A febrile, unwell child with inability to weight bear is septic arthritis until proven otherwise. Okay, so make sure you've ruled that out first. In the examination, you use the systematic look, feel, and move approach. You check for antalgic or Trendelenburg gait. You check for reduced abduction and internal rotation, for any fixed flexion deformities, any obvious limb length discrepancy, which is often a late sign, to be honest, and you assess both hips and complete a knee exam, as we discussed in the SCIFI case, as per Hilton's law, and sometimes you get referred knee pain, which actually may be from the hip. Investigations should be in an organized, structured manner, starting from bedside observations to the trauma bloods, including FBC, CRP, ESR, to calculate the Cocker score to rule out septic arthritis. You want to get your x-rays, AP pelvis and frog leg lateral, and an MRI at a later stage, but request it early if disease is suspected. And then senior discussion with a pediatric specialist or a pediatric orthopedic department or your trauma MDT the next morning to ensure that this patient is followed up early in clinic. Management depends on age, stage, and severity, particularly in the Herring group. Aims of the treatment are to relieve pain, maintain or restore range of movement, maintain containment of the femoral head within the acetabulum, and minimize long-term deformity. The first line in most children under the age of 6 and 7 is non-op management, and those with good prognostic features. The main thing is activity modification, not for strict long-term non-weight bearing, but modify your activity to not worsen impact to that hip. Simple analgesia plus NSAIDs, physiotherapy focusing on abduction and internal rotation, and regular clinic and radiographic follow-up. Operative management can be considered in older children, normally above the age of 8, with Herring B and C classified children with loss of containment and progressive collapse. Options here include a varus femoral osteotomy or a pelvic osteotomy, and the principle is essentially containment. Surgical decisions should involve pediatric orthopedic specialists and an MDT discussion. Definitive outcomes include the final femoral head shape at skeletal maturity determines the long-term prognosis. Poor prognostic factors are old age at onset, a Herring C, female sex, lateral extrusion, and patients should be counseled that some will develop early osteoarthritis and may require arthroplasty in adulthood. So that's it for this episode of Perthes disease. You've got to remember that this is a small topic under the umbrella terms of a limpic child or a painful hip, and you want to ensure that you rule out everything else and then slightly understand the complex pathology of AVN in children that results in Perthes disease. I think this is as much knowledge as you require at the St3 level, and I wish you best luck in your revision, and I'll see you in the next one.